Hey guys, let's talk about the medicinal chemistry of antitussives, expectorants, decongestants, and antihistamines. This actually will cover both lectures on Monday and Tuesday, January the 23rd and the 24th. Before I start, let me remind you that any comments I add to this video is for your own education. You will be only responsible for the written material. So first, let's go through the objectives. As you go through the notes, I want you to be able to explain the mechanism of action of the dextromethorphan and how does it cause euphoria, and although it is not an opioid drug. So think about the opioid drugs as you will see the notes, for example, the codeine comparing to the dextromethorphan, and what's the difference between these two. And then I want you to know the mechanism of action of the benzenotates, the generic for Tessalon, and also to evaluate the efficacy of the guaifenesin in treating cough. Basically, what does the data talk about that? And then relate the chemical structure of the products of the nasal congestion to their mechanism of action, adverse effect, and drug interactions. In fact, drug interactions, something you should keep in mind anytime we talk about these any medication. Also appreciate the similarity between the pseudoephedrine and the methamphetamine, which would explain the reason how these meth labs work. Explain the rebound nasal congestion as it occurs with the local decongestants, but not the systemic decongestants. Make sure you can explain why is that. And then recognize the structural features important for the activity of the antihistamines, both the first generation and second generation. And then identify or realize the side effects associated with the use of the antihistamines, mainly the first generation, and their contraindication with other drugs and diseases. And then explain why special pops like geriatrics and pediatrics should avoid certain products of these antihistamines and the mechanism of action of such problems that are caused by the use of first generation antihistamine. And then finally, of course, recognize the drug interactions and adverse effects for all these medications listed here.
Okay, so here we're going to talk about just two classes of cough medications, the cough suppressants and the expectorants. To begin with, the physiology and the pathophysiology of the cough is complex, and we still do not have a full understanding of the mechanism of action of the cough medications, in particular the opioid antitussive drugs, which are the most common drugs for suppression of the cough. We still don't have the full understanding of it. But it's believed that they are involved in inhibiting the sensitivity of the cough receptors. And that is likely to happen both centrally and peripherally. So to start with the cough suppressants, the first one is the codeine, which is a full agonist at the mu opioid receptor. There are actually three types of opioid receptors that we will discuss in later sessions, but for now, it's a full agonist at this opioid receptor, which is the receptor responsible for the euphoria and the pain that people experience when taking codeine or morphine. The codeine is actually also responsible for analgesic, anti-diarrhea, antihypertensive, anxiolytic, antidepressant, sedative, hypnotic, and of course the antitussive effect. And like we said, we believe that it decreases the sensitivity of the cough receptors, whatever these cough receptors are. We are not sure if it's the opioid or some other sigma 1 or 2 types of receptors. There are many theories. And the most serious side effect for codeine or for the opioids in general is actually the respiratory depression, which is the major cause for the drug abuse of these medications. So from codeine, we would like to design another drug that would produce the antitussive effect, but at the same time does not cause the euphoria and the other addictive effects that we see. And therefore we introduce the dextromethorphan. So the dextromethorphan is actually very similar to the codeine if you compare these two structures, except we have removed some parts here that were not necessary for the activity of the drug. They can still bind to the mu opioid receptors. What is more interesting is the fact that the dextromethorphan is an isomer. It has two forms. One is the dextro and one of the levo. And apparently the levo form, which is the mirror image for this, is the one that binds to the mu opioid receptors and causes all these euphoria and addiction, while the dextro still binds to the mu receptor, the mu opioid receptor, but in a much lower potency. And therefore this is an advantageous because the dextro and the levo both have the same efficacy as antitussive, but the dextro has less effect as a euphoria drug, unlike the levo. So we could provide the dextromethorphan as an antitussive to receive the full effect, and at the same time has less euphoric effect and less addiction. Yet there are still some abuse for the dextro. But how can this happen if it binds to the mu receptor with low affinity? Apparently, by overdosing the dextromethorphan, you will have the chance of increasing the binding of this drug to the mu opioid receptor and attaining the euphoric effect. So this explains why about 10% of teenagers admit that they have been using the dextromethorphan for euphoria. Okay, so I spoke about the codeine dextromethorphan as cough suppressants through the opioids, and both are opioid receptor agonists. The third example of a cough suppressant is the benzonatate, and by looking at the structure, it's completely different than these opioid drugs or the opioid receptor agonist drugs. It is not an opioid, obviously. It is not narcotic. It does reduce the cough by locally anesthetizing the stretch receptors located at the lower airways of the lung, and thus reduce the cough reflex at this source, at the lower lungs. So by taking a deep breath and with the presence of benzonatate, it anesthetizes these stretch receptors and thus prevent the cough. And the nice thing about it that there is no any addiction or abuse of this drug. The second class of drugs that are used for cough are actually the expectorants, and I want to say the expectorants are different than the mucolytics. I'm sure you have read this in the materials by Dr. Coyne. So expectorants actually increase the secretion. They increase the volume of the mucus, and help with the removing the things that causes the cough, while mucolytic would actually make the mucus more thin. So this is just to compare between the definition of an expectorant and mucolytic. We do not have any mucolytics actually in the market. We only have expectorants, which is guaifenesin, available as an over-the-counter. However, there has not been enough data to support the efficacy of these guaifenesin in treating the cough. So there's still a controversy whether guaifenesin should be used to help with the cough or not. Decongestants, they work through the activation of the alpha receptor, mainly the alpha 1 receptor. They cause the vasoconstriction, leading to inhibiting the release of the plasma fluids into the nasal sinuses, and thus reduces the congestion. The endogenous molecule that binds to the alpha-1 receptor in the body is the epinephrine. This is the structure of the epinephrine. And since we need to produce a similar effect to the epinephrine, we need to design an agonist that binds to the alpha-1 adrenergic receptor to produce the decongestion effect. So we could provide epinephrine, but we designed the phenylephrine, which mimics the epinephrine structure except for the OH group. What advantage do we have by removing the OH group that is para position from the epinephrine and produce the phenylephrine? The advantage of removing the OH group is by removing the OH, it's no longer a catechol group. There is an enzyme called catechol O-methyltransferase, a metabolic enzyme that is responsible for the degradation and the inactivation of this molecule. And it only works on molecules that contain the catechol group. Catechol group is basically this phenyl with the OH group. So by removing one of these OH group, it's no longer a catechol group, and this enzyme is not able to degrade the molecule. So it stays longer in the body, and it has twice the duration of action of the epinephrine. But the question is, by removing an OH group here, don't we lose the affinity of the molecule to its alpha-1 receptor? That's true, it is reduced, but not to a large amount. We still have the drug considered as potent. We still have the phenylephrine considered a potent agonist to the alpha-1 receptor and causing the vasoconstriction. And it is actually a very widespread medication that's given orally and topically, like in the nasal spray, and it has the side effect of increasing the contractility force, the heart rate, the output of the cardiac muscle, leading to increase in the blood pressure. So it should not be given to people who have problems with blood pressure, high blood pressure, or people who have arrhythmias, which is the basically irregular heartbeats. Okay, so this is an important concept. Anytime you dispense decongestant, be aware that it will increase the blood pressure and might increase the heart rate, so to be avoided in people with arrhythmias or hypertension, which is actually common. Hypertension is common in older people, so you want to make sure it's given with caution to older people. The second example of a decongestant that also work through the alpha adrenergic receptor, is the pseudoephedrine. By comparing it to the epinephrine, the endogenous molecule, you would see the two OH groups here removed, and you will have a CH3 group here added, besides the difference in the stereoisomerism in this atom. They act the same way as the phenylephrine, so they should also be cautioned in people with high blood pressure or arrhythmia. They are under restriction because they have very similar structure to the methamphetamine. In fact, the only difference between the two is the OH group here. So there has been some abuse of the pseudoephedrine being converted into the methamphetamine in what's called the meth labs, and that's why there's a restriction on the the selling of the pseudoephedrine. The third example on the decongestants drugs are the oxymetazoline, sold under the brand name Afrin, and it is actually available as nasal spray. It's most commonly used in a nasal spray, although it could also be given orally, but it's mainly available in nasal spray. I should also say that phenylephrine is also available orally and as nasal spray, but the oxymetazoline is more commonly used in the nasal spray because of its ability to promote the constriction of the nasal mucosa. So it's used locally as a nasal spray, and it binds to the alpha-1 agonist and alpha-2 agonists, although partially, and causes the vasoconstriction. The oxymetazoline is actually of highly ionic nature because of the presence of the imidazole group here, that is at physiological pH, causes the ionization of the nitrogen here. And this is very advantageous in preparing the topical solutions. So it is used as nasal decongestant, and it's also used in eye drops. It is also advantageous because it limits its access to the CNS. So the fact that it's ionized is gonna reduce the ability of the oxymetazoline to cross the blood-brain barrier and reach into the CNS. The lipophilic substitution of this methyl group here and here at the ortho position from this ethylene bridge, the methylene bridge, the ortho substitution of these two increases the agonist activity to alpha-1 and alpha-2 receptors as compared to beta receptors, of course. It's also assumed that the presence of this bulky lipophilic group, the isobutyl group, at the para position or at the meta position increases the selectivity to alpha-1 receptors and reduces the selectivity to alpha-2 receptors. Finally, there is one important thing to remember when using topical decongestants, whether it's the oxymetazoline or the topical phenylephrine, which is that the extended use of the topical decongestants, and by extended we mean from 5 to 7 days, this can cause what's known as rebound nasal congestion, or also known as rhinitis medicamentosa, which is due to the constriction of the blood vessels in the lining of the nose, which means that by constricting these blood vessels locally only, because we are using topical decongestants, local decongestants, this can cause rebound nasal congestion, which means the minute you stop this topical decongestant, the congestion is going to come back again, because they're only applying these decongestants locally, not systemically. And this occurs in 5 to 7 days of the use for these topical decongestants, and it does not occur for systematic decongestants. So you want to make sure if somebody is using the topical decongestants that they shouldn't apply them more than 5 to 7 days. I also want to say that typically what happens is that people who use these topical decongestants for 5 to 7 days, after they stop, they come back with the congestion again, and they think now they have developed an addiction to these decongestants. They don't realize that it's actually what's the symptom that's called the rebound nasal congestion. Just something to keep in mind. Let's start with the antihistamines, and I'm going to start with a brief introduction to histamine and their role in the allergy, inflammation, and the congestion. First, histamine is synthesized through the decarboxylation of the amino acid called histidine. As you can see here is the amino acid histidine, and it is decarboxylized by removing the carboxylate group using the enzyme histidine decarboxylase, and the result is histamine. As soon as the histamine is synthesized, it has to be stored into vessels or granules. If not, it's going to be metabolized and inactivated. So it does not stay long in the body unless it is stored. So the histamine is stored into vessels or granules, and these granules can be found into 4 types of cells. The first 2 are called the mast cells and the basophils, which are types of white blood cells, and they are responsible for the allergy reactions that occur basically by the activation of the antibodies on the surface of these cells by an antigen that leads to the release of the histamine. These antibodies that are at the surface of the mast and basophils cells are called IgE. The other 2 types of the cells where the vessels that contain the histamine are found in are the CNS in the brain, and in this case the histamine acts as a neurotransmitter. And then the 4th type are the enterochromaffin-like cells, which are available in gastric glands next to the parietal cells in the stomach, and upon the release of the histamine, the gastric acid is released. All the information I provided so far is just to give you a brief introduction about the histamine, their synthesis, and their release. So based on what I said so far, you can imagine the ways where we could prevent the histamine action. One way would be preventing the synthesis of the histamine by inhibiting this enzyme. There are a couple of drugs available, but they are not commonly used. And another way is by stabilizing the mast cell, which are used to store the vessels containing this histamine, and these are called mast cell stabilizers. Examples of them are the cromolyn and the nidochromelin, and we are gonna talk about them when we reach to the allergies and the drugs used for allergies of the eyes. And the 3rd type, which is our topic today, is by designing drugs that inhibit the histamine receptors. So let's talk about histamine receptors. There are 4 types of histamine receptors: H1, H2, H3, and H4 histamine receptors, and they are distributed in different parts of the body. The H1 histamine receptors can be found in the smooth muscles, endothelial cells, and in the brain, in the CNS. The ones in the smooth muscles are available in the bronchi, GI tract, and the uterus. And in the case of the bronchi, the release of the histamine causes a contraction of the bronchi, leading to bronchoconstriction, which is one of the signs for having the allergy. And the release of the histamine at the endothelial cells leads to the contraction of these cells and increasing the permeability of capillary walls, and increasing the blood flow to the extracellular spaces, and this process leads to the edema. In fact, it is because of the action of the histamine at the H1 receptor in these 2 sites that we end up having the allergic and hypersensitivity reactions that can also lead to what's known as anaphylactic shock. The 3rd part where histamine can be found is at the CNS, in the brain, and in this case the release of the histamine from the vessels in the brain makes the histamine act as a neurotransmitter, and they can play a role into the neuroendocrine control, the cardiovascular regulation, and thermal body weight regulation, as well as the sleep cycle, and affecting things like the nausea and motion sickness. The second type of the histamine receptors are H2 receptors. They are found into the parietal cells of the gastric mucosa, and they regulate the release of the gastric acid. In fact, as we will see, in order to treat gastric acid reflux, we will be using products like H2 histamine receptors inhibitors or antagonists. The third type of the histamine receptors are available in the CNS, like the H1 receptors, and they actually regulate the release of histamine as well as other neurotransmitters. They act as an autoreceptors as well as heteroreceptors, which means they are located at the presynaptic cleft, and they are responsible for the negative feedback inhibition of the histamine synthesis and release, as well as other neurotransmitters such as dopamine, GABA, acetylcholine, noradrenaline, and serotonin. Finally, a fourth type of histamine receptors recently discovered play a role into the immune responses. Before we move into the next slide, I just want to say that the fact that we have more than one receptor available in different parts of the body is actually very advantageous in designing drugs to treat conditions like the allergies and the hypersensitivity reactions. Like in this case, we could design inhibitors for the H1 receptors that will take care of these symptoms of the bronchoconstrictions and edema resulting from the allergic reactions. We can also design drugs specifically for the H1 receptors to help with the sleeping aid and even to help with the nausea and motion sickness. And we can design certain drugs to target the H2 histamine receptors to treat the diseases resulting from the increased acid secretion. So I just want to say that this is a very unique case where you have different receptors distributed into different parts of the body, and then we can take advantage of that and design a selective toxicity, selective drugs. Reminds us of the concept of the selective toxicity and the magic bullet or the silver bullet that we spoke about in session 1. So this is an application that we see here. Before we move into the next slide, let's see how we could actually explain how one histamine, in the next slide we'll explain how one histamine molecule is able to bind to these 4 different types. Okay, so how can one molecule bind into these 4 types of receptors? I hope you still remember the case of the acetylcholine and how it could bind into 2 different types of the cholinergic receptors. One was a nicotinic and another was a muscarinic. And we explained in an exercise number 8, we created a video to explain how that same molecule can bind into 2 different receptors by changing its conformation through rotation into a single bond. This is an example. This is another example of this concept where this same molecule, the histamine, binds into H1 and H2 receptors through its trans conformation. So this is the molecule, this is the Newman projection, and you will see that the trans projection, the trans conformation is preferred for H1 and H2, while the gauche conformation is preferred for H3. So what about H1 and H2 receptors? How can one molecule bind to them? Apparently studies shows that for the H1 receptor, it requires only 2 of these nitrogens to be present. This here forms an ionic interaction. This one here forms a hydrogen bond. while for H2 receptor, there is another spot here in the H2 receptor that requires the presence of this nitrogen. So this same molecule binds to two different receptors by forming different types of interactions. And I just want to say there's not much known about how the histamine binds to the newly discovered H4 receptor. Okay, so we have seen how histamine and the histamine receptors play important role in physiological functions. Today we will focus only on the H1 histamine receptors and how we could inhibit these receptors to help in treating conditions like the nasal congestion and allergic reactions and inflammations. Okay, to start with, the general structure for the H1 receptor antagonist is in this graph here, and this is applied to all the H1 receptor antagonists. As we will see later, there are two generations, first generation and second generation, but this general structure should be applied to both generations. So looking at this structure, let's see what are the similarities between the histamine and the basic structure for the antihistamine. As you might remember, we really do not have to have the copy of exact structure for the histamine, because what we are trying to do is actually produce an antagonist effect, not an agonist effect, which means that we might have some features similar to the histamine, but we are looking for other features to block the receptor and makes an antagonist effect. In fact, speaking of the antagonist effect for the antihistamine, the majority of the antihistamines are actually produce their antagonist effect through an inverse agonist. So they are not actually neutralizing antagonist, but they are an inverse agonist. Hopefully you still remember what is an inverse agonist, which is basically the ones that will reduce the intrinsic activity for a receptor instead of just blocking the or neutralizing the activity for the receptor. So the majority of the antihistamines are actually inverse agonists. They are not antagonists. Okay. So now let's start with the structure. Let's talk about the structure, the basic structure for antihistamine. The general structure for the antihistamine is basically composed of two aromatic groups here, connected through a link to a tertiary amine. Okay. Now these aromatic groups, they could be phenyl group, you could be thioneal, or they could be a pyridyl group, and they can be linked together. Basically, you could have you could have aromatic ring, another aromatic ring. They could be fused or linked together, but if they are, they must not be a coplanar. So you cannot have, for example, 3 aromatic cycles. You can have one aromatic linked through a cyclohexane or a cycloheptane, just to make sure that the angle between these two is not 180 degrees, meaning that these two groups are not coplanar. Then these two groups are connected with one atom here, in this case the X. Examples of the atoms that could connect these aromatic groups are nitrogen or CH or CHO, and we'll have each one of these giving us classes or names. And then the X atom here is connected through a link, and this link is usually 2 to 3 atoms, with 2 as the preferred one for the antihistaminic activity. In fact, having 3 atoms can produce side effects and will reduce the antihistaminic activity. And we will see in some other CNS medications that having 3 atoms could produce different effects than the antihistamine. So the bottom line is having 2 atoms is the preferred one. And course, this is called a spacer. So the length of this spacer could be 2 or 3 with 2 preferred. And then finally you have the basic nitrogen, which contains 2 alkyl groups. The alkyl groups could be methyl, or they could be an alkyl group of the length 4 to 6, or they could be, for example, one of them could be a methyl, the other one could be benzyl, which is aromatic with CH2, for example. Notice that when we compare the general structure to the histamine, the major difference is having these 2 aromatic groups, which are responsible for having the inverse agonist or the antagonist effect for the antihistaminic groups. Finally, let's talk about the different classes of antihistamines, and they are based on the X here that's connecting the aromatic groups. So if we have a nitrogen connecting the aromatic groups with the spacer, then we will have ethylene diamine. The name comes from the fact that we have ethyl group, and then you have 1 nitrogen here and then 1 nitrogen, so that's diamine, ethylene diamine. Now if you have an NCH group connecting the 2 aromatic with the spacer, then we end up having a group called piperazines or cyclazines. And if you have an OH group for the X group, for the X atom here, we call it ethanol amine, because now you have the amine and you have the ethanol group, C, C, and O. This is ethanol. And if you have a carbon in place of the X, it's called propylamines. Propyl comes from the fact that it's propane. Now you have 3 carbons, propane, propylamine. And finally, if you have these 2 aromatic rings fused or linked together with a third one in between, then it's called tricyclic antihistamine, because obviously you will have 3 cycles, one aromatic, and another one. But remember, like we said, if they are fused, then they should not be a planar. They should be non-coplanar. There should be an angle that's not 180 but less than 180 between the aromatic groups, because this shows to be important for the antihistaminic effect. Finally, I just want to say that I do not expect you to memorize all these features I described, but if you are provided with this general structure, then I expect you to know that, for example, these 2 aromatic groups should not be planar. If they are fused together, they can be fused together. The spacer here should be 2 to 3 with 2 as the preferred, and examples of basic nitrogens could be one of these. And then as far as the classification, I do not expect you to classify these based on memorizing what's going on the structure, but I would probably provide you with this table and this structure and some examples like we'll see in the next slide, and then you'll be able to match with where each structure belongs to. Okay, so like we said, there are 2 generations of the H1 antihistamines. The first generation you have these examples of. So try as an exercise to map each one of these molecules into its class. See what is the connecting group here and what is the name of which class does each of one of these belong to. So examples of the first generation antihistamine are the commonly named Benadryl or diphenhydramine, and then you also have the doxylamine. And in fact, these 2 are used not only for allergic reactions, but they can also be used as sleeping aid medications. In fact, doxylamine is provided and is given under the brand name Unisom, which helps in sleeping. And you have also other examples of the first generation antihistamine, such as clemastine under the brand name Davist, and you have phenyramine, and then if you add a chlorine group here, it becomes chlorphenyramine, or if you replace it with a bromine group, it's brompheniramine. Okay, and another thing I want to mention about the diphenhydramine in particular is that it's been documented that it causes paradoxical reaction among children, causing excitation instead of sedation. Anytime we say paradoxical reaction, it means you have a paradox, which means that the effect of the drug is the opposite of the expected. So the diphenhydramine is expected to give sedation, but it was documented that for some children, the diphenhydramine would cause excitation, and the explanation for this is due to the fact that those selected groups, or these children, they are considered an ultra-rapid metabolizers to the diphenhydramine through an enzyme called the CYP2D6. So it's believed that these kids, they have this enzyme which is responsible for converting the diphenhydramine into a compound that causes excitation. And this excitation does not happen all the time, only in few children. This is actually one of the reasons why the first generation antihistamine is not recommended for children in general, not just neonates. The other thing I want to mention about the H1 antihistamine, the first generation H1 antihistamine, is their adverse effects. They have GI disturbances, adverse effects such as nausea, vomiting, diarrhea, constipation, anorexia, or increased appetite. But they also have side effects due to their peripheral action on the cholinergic receptors, producing anticholinergic effects such as blurred vision, dysuria, maturation, urinary retention, constipation, dry mouth, tightness of chest, hypotension, muscular weakness, and tinnitus. So these are the peripherally side effects of the first generation antihistamine. More important is the fact that these first generation antihistamine, they cross the blood-brain barrier. So when they cross the blood-brain barrier, they act into the CNS in the brain and produce effects by first inhibiting the H1 receptor in the brain, and this causes sedation, drowsiness, anti-emetic effect, and appetite stimulant. And actually, each one of these effects could be designed to be used to treat certain diseases. For example, although these are side effects, but they can also be they could be taken an advantage of to design sleep aid medication. They can also be used to design drugs to help with the nausea and vomiting, and they can also be used as appetite stimulant. In fact, one of the antihistamine called cyproheptadine is an appetite stimulant to help people gain weight. Another CNS or centrally adverse effect for the H1 antagonist on the brain is by blocking the cholinergic receptor and producing antimuscarinic effect, and this is a central antimuscarinic effect, different than the antimuscarinic effect peripherally. And in this case, these drugs should be avoided in people who have psychotic problems. In fact, some of these antihistamine have been modified further to design anti-Parkinson agents, as we will see later in later sessions when we talk about psychotic drugs and anti-Parkinson drugs. I also want to add that with the case of blocking the cholinergic receptors, or because of blocking the cholinergic receptors, these drugs, the first generation antihistamine, should be avoided in elderly because elderly people are more prone to developing Alzheimer, and Alzheimer has been related to the reduction of the acetylcholine in the brain. So by blocking these receptors, we are actually inducing the Alzheimer. So this explains why first generation antihistamine should not be used. Another central effect of the antihistamine first generation is blocking the dopamine receptor, and thus they actually should be avoided in the case of people with psychotic diseases. In fact, further modification of the antihistamine led to the discovery of antipsychotic agents. And additionally, you have other effects on the adrenergic receptors and serotonergic receptors. But generally speaking, the central effect of the first generation antihistamine, because they cross the blood-brain barrier, causes CNS depression and other effects such as muscle spasm, anxiety, confusion, irritability, tremor, tachycardia, and respiratory depression. So because of all that, first generation should be avoided for neonates or even children, because as we explained here, the paradoxical reaction. They should also be avoided in elderly because of the chance that they might develop Alzheimer, and they are contraindicated for acute asthma attack because they might cause respiratory depression. However, this is an issue under discussion that we could actually talk about in class, which is how can first generation be contraindicated during acute asthma attack, while in fact the histamine itself also causes to the bronchoconstriction. So you would think logically that an antihistamine should help avoiding the bronchoconstriction. So just keep that in mind, think about it, and hopefully we'll talk about it in class. Hopefully we'll find an application for it. And finally, in order to separate the central effect and avoid all these effects that are produced by first generation, another generation, a second generation, was designed that does not cross the blood-brain barrier and does not cause these central effects. Or in other words, they do not they are less likely to cross the blood-brain barrier and reach the brain. And this is going to be the second generation antihistamine that we'll talk about. And we do this by making these second generations molecules more polar and making the size of the molecules larger, such that it's more difficult for them to cross the blood-brain barrier. So I just want to add that with having a second generation antihistamine, we will be able to use them for elderly people, and if we have to use them for children, we can use them. And they are still contraindicated for asthma, although there is some studies that shows that some of them can actually help for asthma. But for now, let's just avoid any antihistamine, regardless of whether they are first or second generation. Let's avoid them in case of the asthma. And I also remembered one thing, which is with the among these central effects, sometimes we could actually use these effects to our advantage, like to design anti-Parkinson or to design antipsychotic drugs, improve the appetite, to treat the nausea and vomiting. In fact, the Benadryl has been used for that purpose. So you have Benadryl being marketed as allergy relief medication, and at the same time marketed as a sleeping aid medication and as a drug to help with the nausea and vomiting. So this is really a very interesting class of medications, the antihistamines, because you can see how these receptors, their distribution, the differences between them and their distribution at different parts of the body can advance our design of selective drugs. Okay, so here comes the second generation antihistamine. Let's see how these structures are different from the ones before. The main difference you would notice is the size of these molecules. They are basically larger than the molecules we had in the first generation, which makes them more difficult to cross the blood-brain barrier. And another thing is that they are more polar. You would see groups like the COH here, and then the nitrogen here that causes the ionization, and then we have this ester here that breaks and also causes the ionized function group. So with these groups, second generation, with these kinds of structures, they are actually less likely to cross the blood-brain barrier and cause the central effects we discussed in the first generation. I want to say examples of these second generations are the fexofenadine, Allegra, cetirizine, and loratadine and the desloratadine. In fact, loratadine, which is an active form, is metabolized in the body to another form, which is the desloratadine, also an active medication. So these two are basically very similar because one leads to the other, and so the design of these, this one is just slightly advantageous. Okay. Finally, in this table, I don't expect you to actually read everything in it. I just want to show you the pattern of the actions we have among the first generation and the second generation. So all these are first generation, and the second generation starts here. And then you have the sedative effect. Notice that the first generation has more sedative effect than the second because it crosses the blood-brain barrier, of course. And then you have the antihistamine H1 effect, which is basically both. For both, it's about the same. That's expected, of course. And then you have the anti-muscarinic effect, not peripherally but centrally, which is more into the first generation and less into the second. And finally, you have the anti-emetic effect. You have molecules like the diphenhydramine, the Benadryl, which has anti-emetic effect, and you have some other molecules that also have anti-emetic effect. Okay, so again, this is just to give you a general idea of what's going on. Finally, I want to say that antihistamine alone should not be used in treating nasal congestion. They should be combined with decongestants.